Today we're going to focus on something that I think is really important. And what's really important is high bleeding risk. So over the next 10 minutes or so, I'm going to try to discuss why it's important, how common it is, and what do the guidelines tell us about how to treat these high bleeding risk patients. So why is it important? Well, as you know, when we do PCI, we're always thinking about different things, and the things we think about are the ischemic risk versus the bleeding risk of the population. And so we're always trying to think, how do we balance these? And in fact, our guidelines tell us that we have to think about ischemic and bleeding risk. These are the 2020 guidelines, and you can see the guidelines very much adopt a personalized approach, depending on whether it's high ischemic risk or high bleeding risk. So both the type and the duration of antiplatelets will depend on the balance of these factors. Now, why am I here talking about bleeding risk? Well, bleeding's important. This is a paper that my group published in 500,000 patients. And what it shows is, if a patient has a major bleeding complication, they are at 3 times increased risk of mortality. So that's really important. So how do we define high bleeding risk? Who are these patients? Well, really the first idea about developing a high bleeding risk population came from the Leaders-Free trial sponsored by Biosensors. And you can see that they had different inclusion criteria that we all understand to be patients at high risk of bleeding complications. More recently, the Academic Research Consortium for High Bleeding Risk have defined these criteria as being HBR criteria. Any criteria that has greater than BARC 3 to 5 risk of bleeding of greater than 4% at 1 year is defined as high bleeding risk. And they also defined minor criteria. I'm going to keep this slide on for a few seconds. This is probably the most important slide for this part of the talk. And if you've got a camera, take your phone out, take a photograph, because this really tells us who these patients are. And when we're thinking about high bleeding risk complications, we're thinking about patients that are elderly, that have comorbidities like renal disease, liver disease, cancer, patients that are anemic, have low platelet counts, patients that had previous history of stroke or a bleeding history, and iatrogenic if you prescribe patients with anticoagulant therapy, if they have planned surgery. All these factors define high bleeding risk. And they've been divided into major criteria and minor criteria. And so it's important when you see a patient to think about how common this is. So this is a paper from Mount Sinai from the US. And really what this is telling us is that high bleeding risk is common. It's not a rare thing. It's not 1% of the population. Nearly half of all patients undergoing PCI are high bleeding risk patients. This is a common problem. But being high bleeding risk also makes these patients high ischemic risk. And you can see in this population, the more criteria they had, the greater the risk of mortality, the greater the risk of myocardial infarction. This is data from my group. I published this, I was the senior author, in over, well, probably 500,000 patients. And you can see that in the UK, 1 out of every 3 patients is high bleeding risk and also high ischemic risk. So what do we do for these patients? What are the guidelines? Well, these are the guidelines from the latest recommendations. And what they say is, if you're doing a PCI in these patients, who remember are very common, 40% of these patients are high bleeding risk, then you should give dual antiplatelet therapy for 1 month in the setting of ACS. And your single antiplatelet therapy thereafter could be aspirin, could be clopidogrel, could be another P2Y12. So 1 month dual antiplatelet therapy, that's the guideline. Now you may say, well, okay, how do we know this is safe? Why should we only give 1 month dual antiplatelet therapy in this population? What's the data? I always ask this question. And this is the data, MAMAS DAPT trial. So this was a randomized trial of HBR patients that were randomized either to standard DAPT or 1 month DAPT. And this was the study design. 1 month DAPT, and then they were randomized to abbreviated DAPT, which was single antiplatelet, which could either be aspirin, could either be P2Y12 inhibitor, or standard DAPT. And these were the co-primary endpoints: NACE, MACE, and major bleeding. So the first thing to say is that in terms of overall and for ischemic outcomes, there's no harm in giving 1 month dual antiplatelet therapy. That's really important. When we're giving 1 month DAPT, we're always worried about ischemic events, and there doesn't seem to be any signal. You can see the lines are superimposable, no difference in MACE. When you look at bleeding, though, 1 month DAPT, significantly lower rate of bleeding. And it didn't really matter whether the single antiplatelet was aspirin or clopidogrel, the outcomes were the same. I'd give clopidogrel. If you say to me, I prefer aspirin, fine, give aspirin. Now, the second part of the guideline, which I think is really important, is to use a platform that has been validated in HBR patients. A lot of platforms have data on short DAPT regimes, but these are not HBR patients. So you should look, whatever platform you're using, and think about, has this platform been validated in HBR patients? And what I mean by that is, proper HBR criteria, not old patients. Age is only a minor criteria. You have to think, has this been validated in the ARC HBR criteria? And only 3 platforms have done that. Biosensors has the most data, Biomatrix. And so these are the platforms. So this Biofreedom has had 2 major trials that have assessed its safety and efficacy, both published in the New England Journal, the Leaders Free trial and Onyx 1. I'm going to talk about these trials in my next talk. So I'm not going to talk about the results of these trials. I'll leave that for my following talk. The important thing to remember, though, is when you're treating high bleeding risk patients, use platforms that have been validated in high bleeding risk populations with 1 month DAPT. There are many platforms with short DAPT. Many of them have used only 3 months DAPT, and many of them have not focused on high bleeding risk populations. That's really, really important. So when you do the PCI and you give 1 month DAPT, look at the platform, see whether it's got data, randomized data particularly. And this is some data around the Biofreedom Ultra. Again, the next speaker will talk more about this. This is a single slide. This is a biolimus eluting stent, polymer-free and thin, cobalt chromium 80 microns. So I think in conclusion, HBR is common. It's not a rare phenomenon. It's not something that you encounter in 1% of cases. Close to half of your cases are HBR. So you have to look at the criteria, decide whether the patient's HBR, and adopt international guidelines, 1 month DAPT. I've shown you data that short DAPT is better than long DAPT in this population, the Master DAPT trial. I've shown you the 2023 guidelines saying 1 month DAPT. And my final point is, use a platform that has data and has been validated in this population. So with that, I'd like to thank you, and I'd like to hand back to my colleague.
Thank you, Professor MAMAS. I think that we have another intervention virtually from Dr. Professor Connard, Christopher Connard, from France. Is he connected now? Ah oui, on vous entend très bien.
Marketing pour l'Europe, le Moyen-Orient et l'Afrique. C'est un honneur pour moi ce soir, même virtuellement, de pouvoir me joindre à ce symposium. Ce soir, je vais vous présenter très rapidement donc, notre solution d'endoprothèse Biofreedom Ultra, parler rapidement J'espère que vous pouvez voir la présentation.
Oui, on est en train de voir la présentation et on a un bon son aussi, donc vous pouvez aller. Tout oui.
Merci beaucoup. Comme le professeur MAMAS l'a indiqué précédemment, donc plus de 40% des patients sont à fort risque hémorragique. Donc ce sont des patients que vous voyez tous les jours, pas simplement liés à l'âge, mais aussi à cause d'autres comorbidités. Donc il est vraiment important pour vous d'avoir la sécurité d'esprit, de savoir que votre patient que vous allez devoir traiter peut recevoir un stent qui soit efficace et en même temps un stent qui soit sûr et qui n'aggrave pas les risques de saignement. C'est même le biolimus, qui fait évidemment partie de la famille des limus, mais qui a été designé spécifiquement pour le traitement des coronaires, qui offre une lipophilie bien plus grande qu'un sirolimus, jusqu'à 10 fois plus importante qu'un sirolimus, avec aussi également une longue demi-vie de plus de 28 jours et une haute biodisponibilité. Et c'est ce médicament très spécifique qui permet justement de ne pas avoir de polymère. Ensuite, sur le stent en lui-même, il y a un processus dédié pour le traitement de la surface qui permet, un peu comme une sorte d'abrasion, qui permet d'avoir une uniformité du transfert du principe actif sur tout le stent. Donc, ce n'est pas un système de réservoir comme sur d'autres produits. Une rétention optimale du biolimus pendant la pause et une endothélialisation qui soit rapide une fois le médicament transféré. Donc ça a été le principe de base de BioFreedom, qui est maintenant sur le marché. Je pense que vous connaissez depuis bien longtemps. Mais évidemment, c'était un stent, je dirais, de deuxième génération avec quelques limitations. Donc, un stent qui était en acier avec une maille relativement importante. Donc, il était clair pour nous que si le concept et le principe prouvé et reconnu étaient valides, il était important de pouvoir continuer de travailler sur la pause, sur les questions techniques et mécaniques de tout le système. C'est ainsi que nous avons développé le BioFreedom Ultra, donc où nous avons travaillé et sur l'endoprothèse et sur le système de livraison pour pouvoir améliorer de manière significative le franchissement, mais également la délivrabilité de notre système. Le stent en lui-même a été retravaillé. Donc là, vous voyez quelques éléments. Donc, on a travaillé sur les jonctions, sur les connecteurs, afin d'améliorer la conformabilité, la délivrabilité, donc le franchissement également des sténoses, tout en conservant certains des points forts de la première génération, comme par exemple une compression longitudinale qui soit la plus faible possible et un recul élastique qui soit également très faible. Donc, essayer de garder le meilleur de BioFreedom tout en améliorant les autres aspects. Ce qui fait qu'à la fin, nous avons obtenu un stent aujourd'hui, comme vous pouvez voir sur cette image OCT, avec une conformabilité, une apposition qui est optimale. Pourquoi cet élément-là? Parce que nous pouvons, sur notre stent, offrir une surdilatation parmi les meilleurs du marché, puisque avec un stent de diamètre de 3,5 mm, nous pouvons offrir une surdilatation jusqu'à 6 mm, ce qui vous permet vraiment de travailler et d'optimiser vos procédures. De même, nous avons conservé l'ouverture de maille qui soit très importante, ce qui vous permet de pouvoir avoir accès aux branches latérales et travailler en toute sécurité sur des bifurcations. Au final, nous offrons un stent aujourd'hui qui est vraiment optimisé, qui est de dernière génération avec une facilité de navigation. Parmi les meilleurs du marché, avec des mailles fines, en chrome cobalt, etc. Avec un taux de réussite de dispositif de pose qui est supérieur à 99%. Maintenant, bien évidemment, améliorer les côtés mécaniques du stent, c'est très important, mais il ne faut pas que ça ait un impact sur les résultats cliniques. Et bien évidemment, ce stent a été très largement testé lors d'études cliniques, à commencer par Leaders 3, dont le professeur MAMAS a brièvement parlé, dont je pense qu'il va reparler dans dans son prochaine intervention, où en fait nous avons testé ce nouveau stent contre la première génération. Et ce que vous pouvez voir ici, en fait, c'est que nous avons réussi à prouver que nous gardons la même sécurité aussi en ayant un traitement DAPT de 1 mois, tout en améliorant l'efficacité du stent en réduisant, par exemple, le TLR. Donc, ce que l'on peut dire aujourd'hui, c'est sur notre stent, c'est qu'il est confirmé comme étant aussi sûr à 1 mois de DAPT par rapport au BioFreedom. Il est à noter que nous avons aujourd'hui le seul stent qui soit recommandé dans les guidelines de l'ESC pour 1 mois de DAPT. Bien évidemment, nous ne sommes pas arrêtés simplement à Leader 3 ni à l'étude de Leaders. Donc, nous continuons encore aujourd'hui de tester et de prouver l'efficacité et la sécurité de notre stent dans le plus grand nombre de configurations possibles, avec des études faites par Biosensors, mais aussi des études extérieures, où nous le testons avec différents sous-groupes dans différents pays pour être sûr que nous offrons vraiment un stent de dernière génération qui soit valide pour le tout venant. Donc aujourd'hui, plus de 13 500 patients ont été recrutés dans des études cliniques avec le BioFreedom et le BioFreedom Ultra, aussi bien avec des études indépendantes que des études sponsorisées par Biosensors. Ce qui est pour nous aussi très important, c'est de ne pas simplement se limiter aux patients à fort risque de saignement, je dirais sélectionnés à la main. Donc, pour nous, il est très important que nous offrions une solution que vous puissiez utiliser pour tous les patients. Donc, nous avons un certain nombre de sous-groupes, comme vous pouvez voir ici, dans les syndromes aigus, ceux prenant des anticoagulants de manière orale, donc avec des sous-groupes de chirurgie, dans les diabétiques, différents types d'accès, etc., où à chaque fois, nous pouvons prouver la supériorité de notre solution. Et ce sont bien évidemment des patients qui sont à très fort risque hémorragique, comme vous pouvez le voir ici, sachant que la limite définie par l'ARC est au minimum de 4% de saignement type BARC 3.5 à 1 an. De même, nous avons étendu la recherche clinique non seulement au-delà des études randomisées, mais également sur des registres qui nous permettent d'avoir des données cliniques réelles prouvant la sécurité et l'efficacité sur tous les patients que vous pouvez avoir à traiter. Donc, Et vous voyez, encore une fois, donc nous parlons ici de plus de 5000, 6 000 patients avec des résultats à 1 an et également sur le long terme qui sont excellents, avec des taux de TLR très faibles, des taux de thrombose également très faibles. Donc au final, avec BioFreedom Ultra, nous avons vraiment la conviction de vous offrir un stent de dernière génération qui inclut toutes les dernières performances, aussi bien mécaniques que techniques, pour la pose, pour la procédure en elle-même, combiné à un niveau de sécurité et d'efficacité largement prouvé sur tout le spectre des patients cardiaques, qu'ils soient à fort risque de saignement ou pas. Et bien évidemment, c'est toujours le seul stent avec, recommandé dans les guidelines avec 1 mois de DAPT. Je vous remercie.
Merci beaucoup pour cette présentation et on va continuer avec la troisième présentation, the third presentation that will be given by Professor MAMAS.
So, thank you. I don't understand French. I learnt French at school for a few years, but I followed that, so it was very clear, so thank you. Over the next 10 minutes or so, we're going to move to part 2 of my talk, where I'm going to focus on what's the data for HBR patients and the platforms that we use. And I think this is really quite important because, you know, when you go to these symposiums, there's lots of discussions, but there's very little data, and I believe in data, so I'm going to show you data. So again, why is this important? Like we said before, ischemia and bleeding, two faces of the coin. We often think about these things when dealing with patients undergoing PCI. And we've also showed this slide before, but because I think it's so important, I'm going to show it again. This is how we define high bleeding risk based on age, comorbidities, laboratory factors, bleeding history, and iatrogenic factors as well, things that we do to patients. And again, I'm going to show this slide again because it's very important. This is not something that's rare. 40%, close to half of all the patients that we perform PCI in are high bleeding risk. And this data from Japan as well. So what's the data? Why are we here thinking about using the BioFreedom platform? Well, like I said to you before, the BioFreedom platform has been subject to numerous randomized controlled trials published in the New England Journal. And this was one of the very first ones. This was the first trial to look at using this platform in a high bleeding risk population. And this was a randomized controlled trial many years ago, looking and comparing BioFreedom versus bare metal stents, which at the time was the standard. This was the standard for short DAPT durations. And what did it show? Well, the primary efficacy endpoint was clinically driven target lesion revascularization. And this is what was in the bare metal stent arm, around 10% at 1 year. This is a high-risk population. When you look at BioFreedom, you can see immediately that the rate is almost halved, 5% at 1 year. If you look at the primary safety endpoints, so just look at ischemic endpoints again, you can see 12% at 1 year with the bare metal stent and 9.4% with Biomatrix. And again, 30% reduction. Now, this is an important trial, and you may say, well, okay, that was against bare metal stents. We don't use bare metal stents anymore. Do we have any more contemporary data looking at use of this platform with other drug-eluting stent platforms? That's important, and we do. This is the Onyx 1 global study. And what this trial was patients with high bleeding risk that were randomized either to Resolute Onyx with 1 month DAPT or BioFreedom with 1 month DAPT. And this was a large trial. This was 2,000 patients. This is a large, multi-center, international, randomized control trial. And the primary safety endpoint was cardiac death, MI, or stent thrombosis. And there were a number of secondary endpoints. So I'm going to show you first the 1-year data. And you can see that at 1 year, both platforms perform very well. This is a high-risk population, as you can see. And you can see that event rates were appropriately high for this high-risk population. But there wasn't really much difference between the two platforms at 1 year. Now let's move to 2 years. And this is the 2-year data. And I want you to look particularly at mortality. So you can see that biofreedom was associated with quite a significant reduction in mortality at 2 years with the Resolute Onyx stent. And so in the first, and probably the only head-to-head trial between two platforms, exclusively in high bleeding risk patients, biofreedom was associated with better outcomes at 2 years for mortality. And at the end of the day, that's what we worry about in our patients. When you're doing a PCI, this is a high-risk population. You want to use a platform that's associated with a decrease in mortality compared to other platforms. And this is the data from the New England Journal paper. Now, you may say, well, okay, platforms evolve. We're always changing platforms, and the biofreedom platform has also evolved. The struts have become thinner. We're also using cobalt chromium instead of stainless steel. What data do you have with the newer platform, the cobalt chromium platform with thinner struts, than the older platforms that we did the New England Journal trials that I've covered, Leaders 3 and Onyx 1? Well, this is data from Leaders 3, number 3. And what they did was compare data from the old platform versus the new platform, the stainless steel platform with thicker struts versus the cobalt chromium platform with thinner struts. And the first thing that you can see is that in terms of cardiac death, MI, and stent thrombosis, the newer platform has, a trend towards better outcomes. You can see that hazard ratio of 0.88, although this was not significant. Nevertheless, the important thing to look at is on the right. Clinically indicated target lesion revascularization. And what you see here, that with the new platform, with thinner struts, with cobalt chromium rather than pure stainless steel, there's a halving of target lesion revascularization. So not only have we got a platform that has better head-to-head outcomes in terms of mortality at 2 years compared to Resolute Onyx, but now it's got even better with a 50% reduction in target lesion revascularization. Now you may say, well, okay, this is all great. Show me data. Show me data around short DAPT. I've shown you the master DAPT trial that was only 1 month versus conventional, but there have been a number of other studies. And this is the meta-analysis looking at master DAPT, Twilight HBR, TICO HBR, Stop DAPT2, and Stop DAPT2 HBR. And what they've done is the master DAPT was all HBR. In the other trials, they had some patients with HBR. So they took the HBR subgroups of the other trials. And they combined them. And again, what we're seeing is, whilst there's no difference in MACE, all-cause mortality, or stent thrombosis associated with short DAPT, so it means it's safe. We don't have to worry about increasing risks of stent thrombosis in these groups. We see a big reduction in major bleeding and clinically non-relevant major bleeding. So reductions are around 60%. So this is clinically significant. Major bleeds are not a small nosebleed. These are the sorts of bleeds that will kill you. So short DAPT, good data from this meta-analysis of trials. What's going forwards? What are the next few trials that we have to look forwards to? One of the ones that I think is going to be quite exciting is the ultra left main trial. So this is going to be a trial of 700 patients undergoing unprotected left main. And these are patients that are going to be HBR, and they're going to be randomized to short DAPT versus conventional DAPT. And they're going to look for non-inferiority for patient-orientated clinical outcomes. I think it's going to be really important because, you know, all of us that do left main are always worried about using really short DAPT in these patients. And this is going to be the first trial to exclusively look at that in a HBR population. So I think, in conclusion, what I'd like you to take away from this is, number one, HBR is common. You know, 40% of patients have HBR. Number two, the biofreedom platform has been assessed in multiple randomized control trials published in the New England Journal. What the trials have shown is, number one, superiority with 30-day DAPT over bare metal stents, and number two, superiority at 2 years for total mortality over Resolute Onyx. I think I've shown you that multiple trials now have really said to us that we should be using short DAPT in this population, and future trials using this platform will assess the safety and efficacy in the highest risk patients, complex left main. So with that, I'd like to stop and hand back to the moderator.